Hello and welcome everybody to our workshop, Collaborating for Health Workforce Excellence, Investing in Europe's Health Professionals. And this is a workshop organized by the European Commission, DG SANTE, and we are very grateful that you have organized this. And the purpose of this workshop, the aim is to demonstrate the value of EU-funded health workforce projects addressing the health workforce crisis. And value in both terms, in terms of scientific delivery, that we get new insights, that we get a better understanding of the roots of the health workforce crisis and how to remedy it, but also in practical terms, testing interventions that can make a difference. And we need these interventions and innovations that can make a difference because we see in so many countries in Europe a very serious health workforce crisis. And you know all the facets of it: shortages, attrition, medical deserts, skill gaps are almost everywhere to see. And in some countries, you have different facets of the crisis at once. So we have a very lucky position to have a fantastic panel, actually, that can address these issues and can tell us how can we actually deal with the crisis, how can we analyze it, but also what can we do, what are the interventions that can really help us. And I would like to introduce the colleagues, and they are coming all from EU-funded projects, but we will not talk much about the projects. We will really talk about the evidence and the impact of the intervention. And I would like to start with introducing Lisa Baldini. She's from Agenas, the Italian regional healthcare agent, and you are speaking today for HEROES, a joint action which is actually focusing on forecasting and planning. Next to you sits Esther Kovac. Esther is from the Semmelweis University, and actually you are representing two projects. One is TASHI, and the other one is HPAS, and in a way they are very closely related because they are about skills, task shifting, skill mix, but also digital skills for team working. Next is Federica Margheri from the European Health Management Association. And Federica, you are talking about a very special project because it's about a social partnership run project, Be Well, on closing the skill gap with regards to digital skills and green skills. And next to you sits Marielle Bemmelmans from Vemos. Vemos is running a project, or has actually finalized a project called AHEAD, and the essence of the project is make medical deserts bloom again. So how can we address the maldistribution of health professionals across the territory? And there we have Anke Bohn from Catholic University Leuven, and she will introduce the results and the impacts of Meteor. I know, Anke, you can only pick out a small aspect of it, because it's a very, very rich project, but it's basically about recruitment and retention and also focusing a little bit on hospitals. Having said these are all projects, we don't want to go too much into the details of projects, work packages, and deliverables. We have prepared a tweet with all the Twitter handles of the projects so that you can look them up and delve a little bit deeper in what they have done, what they are currently doing. But before we delve into these topics and the experiences of these projects, it's my great pleasure to introduce to you our keynote speaker and our impulse speaker. Our keynote speaker today is Marco Marcella. He is Director Digital EU for Health and Health System Modernization from DG SANTE, and I think he will give us the context and will help us to understand, what is this all about, what are we aiming at, and what do we expect from these projects for Europe. And I'm also very pleased to introduce Johan van Elderen today. He's with us in his special affiliation with the European University Hospital Alliance. Before we start, just a little bit of an overview how we run this. So we will have Marco giving us a keynote, then we will have the impulse statement, and then we go through the projects and we will hear, what is the evidence and what are the interventions that have already proven to be quite effective. And then we still have like 15 to 20 minutes time for questions from the floor. I will first of all ask Alice for input coming through the chat box, and then you fire away your questions and we will see who can respond to the questions. And finally, we have asked Marco to wrap up the session. So that's the plan. And I would say, Marco, the floor is all yours. Please give us your keynote.
Thank you, Matthias. And let me welcome you all, ladies and gentlemen, for these sessions that we organize at DG SANTE. It is a pleasure to see you all here, and specifically with a diverse range of stakeholders. The reasons why we assembled this is that essentially we wanted to dedicate a session to one of the most pressing issues that are related to health systems, and that is the health workforce. Now, you all know that a crisis on the health workforce is not just a challenge, say, for the professionals or for the systems, but is a challenge for the citizens at large, for our societies and for the patients. So we know that we are all aware that there is a harsh reality, and the data confirms that to us. So we do face the severe staff shortage with doctors. We do the same with nurses, and both categories are actually asked by the day, say, to take on increased workloads in even shorter time frames. Now, this shortage of healthcare workers, it is having a profound impact on our systems, as you well know. And one of the key points that I would like to highlight is also that, you know, as I was saying before, in addition to the challenges for the health workforce per se, we do have an effect on patients with an effect that they are left, say, without supports to answer. This generate stress and it generate hopelessness that you know, they fear that adequate care is not provided to them. Now, so in that we frame the discourse also in terms of quality and accessibility of healthcare, we know, which may have a serious consequence on patient outcomes. Now, this meeting today, it is really to discuss the elements and the evidence that is coming from this project, also in terms of the well-beings of the healthcare workers. Now, let me stress that apart from, let's say, the evidence that is generated by, say, the experiences that are being explored in these projects, we are also realizing the importance of having evidence testified by data. So let me say also in the context of this session that when we will have the European Health Data Space up and running with the solutions, you know, gathering for data may also help us in analyzing better the needs and potentially the way in which we could go forward with that. So what are we doing with the projects that we have now? Well, you know that the chapeau is the European Health Union. We know that we are building on the output or on the experiences of the COVID-19 crisis. We are working to create a health union that better prevent, prepare, and responds to these challenges. And the projects that we are discussing today, they are an emanation of our, say, contribution to the member states for the knowledge sharing and for gathering this evidence. Now, the panel today, it is an opportunity for us to showcase these examples. You mentioned the project Heroes by Agenas, you know, that it is a project that will tell us, as you say, more about planning and forecasting. And we invested 7 million of the EU for Health program in this project, and it is the core of this is to support the planning needs in the member states. And this forum for exchange of practices, it is a place where we would like to see the emergence of solutions that we can apply across the board. There are also 5 clusters of projects that are funded not only for the EU4Health program, but even by the past, which are addressing the problem mentioned by Matthias before. So from a shortage of workers in the medical desert to, in general, skills innovation, tasks shifting, but also retention policies. And we are very lucky to have here the representative of these projects with us today. Now, this cluster of projects has ended, so you will try to consolidate the output of these projects into evidence and into lessons that you can share with us, for all of us to reflect. Now, we are also here the representative of the European Health Management Association, and the reason is that we invited them because they are working in a major large-scale partnership for skills, which is called the Be Well project, that is funded under the Erasmus program with a significant amount of budget, 3.7 million, exactly to address the skills strategy, including for digital and green, that we already heard are important for us today. And we are also supporting 7 targeted training projects for health professionals. And we are touching upon digital skills, the resilience, but also say on how we can, or what are the practices for better integrated healthcare models. And it's a package of actions which is worth about 16 million euro from the EU4Health program. And finally, let me highlight and recognize the role of nurses on the workforce, among the workforces, because you know, they are among those that are the most affected by the workforce crisis, and they are facing overwhelming workloads and increased pressures. And even there, if we look back to the numbers, this is testified by the output of a commission study that says that 61% of nurses, they do experience high job strain, and 69 of them, they reported health and safety risks. Now, these figures, they tell us that you know, that we are situated well above the average of the EU level when it comes to the analysis for surveyed professions. So, and therefore, I'm particularly delighted to report to you that at the beginning of September, we have embarked on a new project with the WHO Europe, with the WHO Europe offices that focuses explicitly on retention of nurses and the EU. And this action will be implemented by WHO Europe. The project will address evidence-based recruitment and retention strategy, but also scaling up mentorship efforts for the new generations of nurses. And it will also focus on the protections of nurses' health and well-being. Now, the project will support countries in implementing staff measures, but also in leveraging digital solutions to the maximum extent. And it will run for 36 months. Now, the member states can also use these other funds, and I want to remember to remind here the importance of the work that we are doing under the European semester and the recovery and resilience funds, because a part of the funds, the 43 billions that are dedicated to investment in healthcare, they do cover the workforce. And there are examples, including in Austria, which established a national worldwide network of nurses out of the recovery and resilience support. So, to conclude, the challenges, yes, are big, but you know, we are all there to support not only the discussions, but also taking forward the output of this project. So I am very delighted that we organize these sessions with such a high level of panel, and I'm looking forward to the conclusion. Matthias.
Thank you so much for this comprehensive overview. And I think it became very clear that the investment of the EU into health workforce and health workforce projects is quite substantial. But it was also very good to hear from you that it doesn't come to an end with the project, that there's continuation with the project with WHO you are running, and also that it's not just on the EU level, but that really member states are benefiting from it. Thank you so much, Marco. Johan, can I ask you, please, you give us a little bit of a perspective in terms of the policy of the health workforce policy.
Thank you Thomas for introducing me, and thanks also to SANTE for inviting me here today. I represent European University Hospital Alliance, which has soon 11 members, just to name them: Karolinska in Stockholm, Charité in Berlin, Erasmus in Rotterdam, Aarhus in Denmark, King's Health Partners in London, all public hospitals in Paris, the University Hospitals of San Raffaele in Milan and Valdebron in Barcelona, of Leuven in Belgium, and last but not least, AKH in Vienna, here in Austria. So what is the aim of our alliance? What we want to do is to learn from one another, share best practices, but also to be influential at European level. And our aim there is to preserve the sustainability and the quality of the European health systems. So a couple of years ago, our CEO said, look, the main topic of the alliance should be the workforce shortage. That is our main problem. Focus on that. So we did what we want to do, which is, we asked all our members, what do you do in terms of retaining, recruiting the best people into your hospital? And we built a repository of 45 odd proposals. And I'll come back to that later. But what we soon realized is that these solutions are short-term solutions, and they will not solve the workforce problem. The workforce problem is a symptom of a disease that is much more systematic. So what we did was we set up meetings with experts. We put together an advisory board with experts from our hospitals, from our affiliated universities, international experts in healthcare. And we came up with a proposal, a position paper called Rethinking Healthcare, which basically says, look, if you want to solve the workforce problem, you need to think in the long term. The long-term structural reform is what is going to solve this problem, not short-term, not medium-term solutions. So what I would like to tell you first today is that we need a structural reform of healthcare in Europe. This needs to be implemented now. We cannot wait. And it will be, in our minds, the only way to solve this problem. Medium-term and short-term solutions can be a bridge to when these structural reform takes form and has all its effects. But they are short-term solutions, and they will not fundamentally solve the problem. So what about these long-term solutions? The structural reform of the healthcare system needs to be a reform whereby there is much more emphasis on prevention, on preventing people coming into the hospital. I don't have to tell you, not this public, what the challenges are, but we think that the only way to solve these challenges and to solve the workforce problem is to prevent people coming into the hospital. This might sound a bit odd coming from a hospital alliance, and we're certainly not going to gain brownie points with the medical professions. But this is what we think is the only solution. And it also has implications. It has implications in the form of infrastructural reform. It has implications in financial terms, reimbursement, and that is probably the elephant in the room. But it also has implications for the way in which we train future caregivers. The way we train our future caregivers now, at this moment, in our university hospitals, is to select the best and the brightest, academically speaking, to become specialists in university hospitals. Becoming a GP or working in primary care is in many cases and in many countries seen as a consolation prize when you cannot become a specialist. We need to rethink that. And to give you one example, one of our members, the Erasmus Medical Center in Rotterdam, has completely changed the curriculum. Instead of having specialists explain pathology, anatomy, physiology, they will be asking GPs to teach these topics, which means they will be less specialized, there will be more emphasis on how to deal with these topics in a primary environment, but it will be needed. And they're also thinking about changing the selection criteria. Maybe not only the academically best and brightest, but the people most excellent to work in primary care and in prevention. I don't need to tell you that this is not an easy thing to do. I spoke to the vice dean of training in Rotterdam, and he has had a lot of opposition from his colleagues, because basically they fear that Erasmus will not be able to preserve its preeminent position in medical healthcare in the Netherlands. But it is something we will need to do, and we will need to start it now, because these people will only come onto the market in 10 to 15 years. And it not only applies to doctors, it also applies to nurses and to other caregiver professions. In terms of medium-term solutions, we are confronted with a changed attitude to work. Work used to be a part of life. Now there's an antithesis between work and life, the work-life balance. This is not only a problem of the Generation Z, of the millennials, it's also a problem of elderly people. When we did exit interviews in my hospital, people leaving the hospital before the age of retirement, we found that in more than 200 people, the biggest reason for leaving the hospital was the time spent traveling from home to the hospital. When we went deeper into this, we found out it was the work-life balance. They wanted to do something else instead of sitting in their car. They wanted to enjoy life. And this is something that is pervading all our caregivers. Work-life balance. They want to do nice things, and they want, if they finish work, to be rid of it. They do not want to think of life. In the past, it used to be that working in the healthcare sector meant you had no hours, and you worked whenever it was needed and until the work was finished. This is not true anymore. This leads to specialists not wanting to go to hospitals where there's only 1 or 2 doctors in their specialty, because it means doing shifts 1 in 2, 1 in 3. This means, for example, that in one of our members, they couldn't find young radiologists unless they didn't have to do night shifts. This is one of the causes for the medical deserts. And we will have to adapt to this. We will need to structure healthcare in such a way that we will do the same thing with more people, or maybe do less. Maybe our healthcare will not be available 24/7 in every hospital. We will need to restructure, and this is something we can do with a 5-year horizon, in such a way that people are still willing to come and work in our hospitals. We also need to take care of the fact that these people want, within their career, to grow professionally and also personally. That is also something we will need to take into account, and especially our nurses. When we did a review of what our nurses wanted in terms of their employment, this was one of the main things. Make our job, make it that it is reassuring and that we can grow professionally and personally. And then finally, we come to the short-term solutions. So we did this review of what we did in our hospitals. We had 45 proposals. 2/3 of them were digital, meaning software platforms, artificial intelligence, telemedicine. When we went to the topics, it was, first of all, patient at home. Second, clinical decision support. Third, platforms to ease the autonomy in the working place, to help people plan their work. My big worry, and I've talked to this with Marco, is that when we looked at the interoperability and the exportability of these systems to other hospitals, we immediately saw there were lots of problems. There are still huge differences in terms of digitalization, the level of digitalization between our hospitals, between our member states. And there's also a problem in terms of data, the way in which we code our data, the way in which we put our data into the system. And a third thing I would like to warn for is that a lot of our workers, caregivers, are afraid of too much digitalization because they think it's going to impact on their jobs and they will not be needed anymore. So these are things we will need to take into account. Let me also tell you a bit about solutions that I do not think are good short-term solutions, and that are temporary workers from employment agencies. This is a poison. It's a short-term solution. It will poison your institution. And for example, one of our members employed a lot of temporary workers, and these temporary workers coming to the hospital, they earn the same wage or even more, they have better hours, and they do the same job. So what do you think is the conclusion of the people working in the hospital? What about recruiting other nurses in other countries in and out of Europe? Without touching on the ethical considerations, which I think are also important, this may be a solution for large language communities, such as English and Spanish, but it is much more of a problem for small language communities, like my own Dutch or Swedish or Finnish. I won't mention French and German. I know it's a touchy subject. But if my hospital went to India to recruit nurses, big enterprise. We succeeded in recruiting 17 nurses from India. We have vacancies for 200. So in the end, I would like to conclude, not all is doom and gloom. We are very happy that there's a growing awareness and willingness to change the system. at every level. We do hope that Europe will be engaged more in implementing these changes. We really need Europe for this. We are too small to do it on our own. We don't want to reinvent the wheel 27 or 28 times. And this would be my final word. I do think we need to start implementing these changes, structural reform of our healthcare system right now, not in 5, not in 10 years' time. Thank you.
Johan, thank you so much for this strategic perspective and this very, very insightful impulse talk. And I think you made it crystal clear. We all know that policymakers across Europe are currently firefighting the crisis, But the firefighting alone is, of course, necessary, but it's not good enough. We need to have the long-term and structural perspective, and primary healthcare is one of them. But you also mentioned a couple of topics which already resonated what Marco was saying and what all the projects are about it. It's about skills, it's about digital, it's about new training ways, new ways of forecasting, new composition of the health workforce. I think we will hear from our panelists picking up on those remarks. But thank you so much, and I think this is really very important that we understand it's not just fixing the current crisis, it goes far beyond, and the crisis will not go away anytime soon because of the demography. That's very clear, because, population is getting older and the demography. And with this, we have more medical needs. We are seeing in many countries at the moment that large numbers of health professionals are going on retirement. And we have the problem of replenishing them because the cohorts from which we are recruiting are contracting, and also many of the professions are not as attractive as they used to be. So thank you so much for this great perspective. And I would like to start actually with Anke from the Meteor project. Even though we've been talking about the firefighting, I think this is something where policymakers very often think we can do this quite instantly, improving the working conditions. And Anke, we would like to ask you, from your research and your intervention, what do you think? What are the lessons? How can we prevent health workers quitting their jobs as professions? Please, Anke, 5 minutes.
Yeah. I don't know, is this working?
Beautifully.
Yeah. Okay, perfect. Thank you, Matthias. I just want to start, on Monday when I arrived here on the shuttle bus, I was very lucky to be seated next to someone who studied to become a nurse, and she didn't become a nurse. She's in policy in public health. So with the Meteor project, we investigated what are the main factors that people leave their job. And we had a focus on mental health and burnout and stress in the job, which was already mentioned also by my former colleagues. And so I was very curious. I just asked her, why did you not become a nurse? Because I was curious if it would align with what our results from the project. And she said, what I really remember is that I wasn't welcomed in the hospital. I wasn't introduced anything. I didn't have any contact person that I could contact when there was a problem. And I had to smile a little because, of course, it's not a good thing that she was telling, but this was also confirmed by our results. And for instance, in the Meteor study, we also conducted a review to look at some numbers. And there we also saw that 20 to 30% of people who graduated to become a nurse in the first year, they actually quit already. So we actually invested in them in their training, and they did the whole training. They still wanted to become a nurse, and then 1 year in the job, and they're out. So this is a huge problem, I think, for healthcare. And the reason was also because of the culture, because of the work environment, and because their expectations were not they wanted to work with patients. They didn't
so it's not the salary.
No, it's not. Yeah, of course, salary is important. I'm not going to be completely naive about it. But even if in our studies, we saw, and it depends a bit on which country, you need a competitive salary, you need permanent contracts, you need job security. So it's also about these factors, these financial incentives. But it's definitely not the main thing. And then I come back to the results now. So what this woman was saying was that she lacked mentorship, that she lacked onboarding. And that was something that was very often mentioned during our workshops, our surveys, our interviews. And also studies have proven that mentorship is very effective for people's mental health and to stay in the job. And And of course, there's no magic bullet solution. So with these things, we're not gonna fix everything. But like the big cluster, we then clustered a bit all the types of interventions that were mentioned in different teams. And the one that was mentioned the most was the professional and personal supports. So this could be addressed by introducing mentorship programs, onboarding programs, also providing psychological supports, easy access to psychological support, but also, and that's what you already mentioned in the beginning, the work-life balance. It's really very important to listen to people and to see what they need. And for instance, you have these self-scheduling programs because we've seen in other studies also for burnout, for mental health, people need some kind of autonomy in their job, some kind of feeling that they're in control of their job and their lives, because they also want to do other things with their life. And if you then give them more autonomy and you control them less in you like top down, like you have to work then and there's nothing negotiable, then that also affects their mental health and afterwards also that people are actually leaving. So you have different types of options, and I think other people will also still mention the skill mix. But
it doesn't seem to be the big things, you know. It's not like asking we need a nursery for our children, we need more income. It sounds like very much organizational issues and organizational culture.
Yeah, it's a combination of everything, of course. That's why it's difficult. Like we need different aspects. Also, the second cluster that we also had was focusing on education, on training. Like people don't want to work constantly in a sense of urgency. They could do that for a small part in the Corona crisis, but now they have aspirations, they have goals. Like we need to also listen in what they want to be educated more in.
In your research and your surveys and working with the hospitals, Anke, have you also seen hospitals or wards that have done it differently, that have done it better, that have fixed some of these issues? Mm-hmm.
Yeah, we worked, for instance, in Belgium also with Hospital AZ Delta. And they also they really invested in onboarding programs, but they also really invested in leadership trainings. So they don't just appoint a good nurse to become the head nurse, like they're really, because it requires also different competencies, and leaders are super important in the well-being of their nurses, their physicians. That was also something that was mentioned. And a good other example could be also the magnet hospitals, which are now also having some studies in Belgium in this model that really puts the well-being of mainly nurses, but it can be, I think, transferred to other...
I could continue to listen to you because it's very interesting, but we are a little bit short of time. Mm-hmm. But actually what you say, I find it very encouraging, because these are not things where you think it's impossible or we cannot afford it, you know. This is a massive investment, this will mess up, you know, the rota system or whatever you have. It sounds like if you're willing and if you're changing the cultural, organizational culture, it should be feasible. So thank you so much, Anke. We're coming now to our second speaker, Marielle from Venus, and I was saying you are making medical deserts bloom, but you know, one of the things about your research which I found so fascinating was it was not just about, you know, well, you have all the indicators, you have the tools to identify them, but you also say, wait a minute, this is also a political and social problem, and there are political and social solutions to it. So yes, let's hear from you. What are medical deserts actually, and what are the solutions to how can we avoid them, how can we fix them, how can we make them bloom again?
Thank you very much. I think I'm well. The microphone is working well as well. A pleasure being here, and indeed within our project and our partners working in 5 countries, Romania, Serbia, Moldova, Italy and Netherlands, we have been zooming in on medical deserts. And when we're talking about medical deserts and the similarities that we all recognize in the different countries, of course, some of it has been mentioned already by you. The decreasing number of doctors and healthcare providers that leave perhaps perhaps to urban areas or to other European countries, or retire and receive no replacement. Also, the medical deserts, often in the more sparsely populated areas with more aging population and their specific health and care needs, and the travel distances to the nearest doctor or hospital, that especially in the larger countries like Romania and Italy was a main barrier. But when we talk about more solutions and differences between these very context-specific and complex phenomenon of medical deserts, we went into policy solutions or options, both on the side of increasing the supply of healthcare providers, as well as decreasing the demand, as Johan also mentioned. And I may mention a few out of the outcomes that we've had in our project within the different countries that are all interesting to mention, but I'll just mention a few. So, for instance, in Romania, there was emphasis on the regulation for GP practices to reduce bureaucracies, and also integration of primary care with community care to reduce the demand on GPs in that sense. And they've also implemented quite successfully more mobile health services, as well as digital tools during the COVID situation that could be continued. Plus, they've actually looked specifically at available funding for these initiatives, including EU funds. And then in Italy, there was emphasis also on improving the digital skills and technical innovation of the health providers, while in Serbia, there was a lot of emphasis on subsidies and incentives for health workers to work in rural areas. Apart that, also specific mandatory temporary placements during internship or residencies on specific curricula for rural health, but also supportive networks for those working in rural areas with mentorship programs that we found very interesting.
So it's a whole toolbox, actually, isn't it?
Yes.
And you apply it really to specific conditions. So one desert is not like the other.
Exactly. Yeah, that's indeed the context-specific policy options came out of, which I will also allude to a little bit, the consensus-building methodology that we used in our approach.
Can I ask you about the role of incentives and money? Because I know a country where the Physician Association has thrown millions and millions and millions of money to rural and remote areas with absolutely no effect. Can it work, actually, giving more money?
Not always, no. That's not always the key solution. I think also one of the previous speakers mentioned that as well. There's more to it. Also, in the Netherlands, for instance, out of this project came also that in a more rural area of the Netherlands, the promotion, or that the area was not so seen as so popular to live in or to move to. So when speaking to the citizens there and finding solutions, they were also thinking about how to promote the region more, and even to involve Dutch celebrities in the promotion of the region. So to attract really the GPs into their region, and to also look at things of provision of housing, of space to open a GP practice there. So there was much more than monetary incentives, I would say. And maybe just to finish on the consensus building methodology, please, if I can. As I think that was a bit special about our program, that we used this participatory approach of public health policy planning to work with a group of as inclusive and representative as possible, with those that were seeing the effects of the medical desertification, so the patient groups, associations of the elderly, the healthcare providers themselves, and those that can actually do something about it, such as the council members, the mayors, the insurers, the healthcare insurers as well, and to come up together with policy options at local level and to bring those up into national level discussions as well. And then you saw that solutions came that had to do with healthcare provision, but also with community mobilization, with volunteers, making it easier for instance, the elderly to navigate through the system and thereby decreasing the demand. So I will stop here as well.
Thank you so much. I think that was very insightful because very clearly, number one, there is a toolbox and quite a large number of tools, of things you can apply in medical deserts. And as you say, not one is the same. They're all different. And secondly, there's also a political social element to it, resolving a medical desert. You need to mobilize the stakeholders, the local stakeholders, and need to connect them with the more national stakeholders, actually. Thank you so much. Very good. And now we come to Esther. Esther, you are here for two projects, and we're getting more and more complex. We started with the recruitment and retention, which is something which many member states are trying to do now, intensify this because they think they can quickly make sure that people are not leaving actually the organizations and the health service. And then fixing medical deserts is already a little bit more complex. But now we're talking about skill mix, and there's a lot of academic literature about skill mix. And many people think this is really the way forward because, as Johan said, we need to reform our health systems and then we need to align the health workforce to it. And we need to work with what we have. And this is in many countries, not in all, but in many countries, it's not a growing health workforce anymore because in some countries we have growth to limits. So please tell us about the skill mix, and also skill mix and digitalization if we have the time. Please, yes. Esther.
Thank you very much. First of all, I must mention that the TASHI project investigated the task shifting between healthcare workers. We did not focus on the different other different types, meaning task shifting to patients or task shifting supported by digital, which in the future have a very, very good opportunities for us. So task shifting should be embedded in care organization and designing the services. This is one of the main lessons that we learned during our project. We did see that we need all levels to know about task shifting. Even the individual health professional has to recognize that he or she is doing task shifting actually. Many countries of our investigation reported informal task shifting. So they do know what is it about, but it's not in an institutional way.
And it's not a grand plan. It's not like embedded in a strategic plan, is it?
Indeed, and task shifting should be systematic and should be really organized by managers and leadership, I must mention here as well. So the organizational level and also the macro level, the policy level must know about it. And for example, in Lithuania, they managed to put in place a regulation on shiftable tasks, and they are continuing to reveal those tasks which are possible to shift to other health professionals. It was a very important point in that country to really operate task shifting on site. The acceptance of task shifting, I must mention, because it's not only the health professionals who giving away the tasks. The willingness to give away the tasks is also important, and the willingness to receive new tasks, for example. I must mention the compensation side of it, because obviously if we receive additional roles, additional tasks, it would be very important and relevant to get compensated for them. And by the way, that can increase the job satisfaction and the career aspects as well. So we did see that it increases the motivational level of the health professionals. And these all become like a big complex package at the end where we see this kind of advantages. But not only the health workforce side, but the patient side, the citizen side is important to get the quick access to healthcare services, even if it's not the professional they are expecting to be there. So basically, if you have an advanced practice nurse in a rural area, but you can really access the care, it's not a doctor, the patient should be also open to receive care from another professional than expected. And the patient education, this part is also a highly important part.
you really run pilots actually on task
Yes.
shifting. Can you fill us in a little bit on the countries and the specific pilots?
Yes, indeed. 3 pilots were focusing on primary care. In Lithuania, we checked the GP practices and how tasks can be shifted from doctors to nurses and nurses to nurse assistants. In Lombardy region in Italy, we focused on GP and family care nurses, which is a new profession, newly recognized profession. So it's a kind of revealing what are the tasks that could be delivered by the new professional group. Also in Estonia, mental health care nursing was in the focus of the pilot studies, which was introduced in education a few years ago. So the first mental health care nurses are out on the labor market, and how to use their skills in the maximum level. This was the biggest question for the Estonian case, and they investigated how the GPs and the psychiatrists can shift certain tasks to mental health care nurses. In Norway, we have wound care nursing in focus. That is a very exciting part of the case studies. They already introduced the task shifting module to wound care nurse curriculum, which is very good. And they are continuing even with optometrists. Because the Dutch case study showed a very nice task shifting between ophthalmologists and optometrists. So it is happening, and these are good practices already.
That's really very encouraging to hear again. So excellent. And I know there's so many other things to say, and you could also talk about teamworks and digital support for teamworks. I think this is a very, very big topic. So I encourage you all to look up Tashi, and HPAS actually is the other one. So the next speaker on my list is Federica, and she's coming now on purpose because we've heard about, already Anke was talking about the skills, the leadership training, but also the training for the nurses. We heard from you that there's more skills needed. We had now very clear input, task shifting skills. And you are running actually a project which is all about skills. It's focusing on digital skills and green skills, but the thing which is very special about it is that it is run or co-run by the social partners, which are really in charge of developing all this. Please fill us in a little bit on it.
Yeah, I think that the key word and the key vision of the Be Well project was really all around collaboration and co-creation. The Be Well project aims to develop a skill strategy on green and digital skills indeed. And already in preparation phase of the project, we didn't want to have just another document, just another skill strategy that is just pretty to look at and great to read, but then we all forget about 5 minutes after. And so how we decided to do that was through collaboration and co-creation. So we wanted not to develop something as a group of partners, but we wanted to have these strategy co-created from the workforce, by the workforce, so that it can really be useful for them. And this is the reason why the composition of the consortium is a very varied one. So we do have researchers, and that is what provides us the evidence base. We have higher education and vocational education training providers. We have association of professionals, so nurses, doctors, managers, junior doctors, and we haven't stopped at the consortium. So we just didn't want to base ourselves on this group of 25 partners, but we wanted to open it up. And so as soon as we developed the first draft of the skill strategy, we immediately also opened a public consultation. And we open a public consultation because it's important that, again, this strategy is created by all of us, by all the stakeholders in healthcare, so that it makes sense for all the stakeholders in healthcare. And so this is why for the remaining 2 years, we are running an open public consultation, which I very much invite you to go and have a look at the bewellproject.eu. And this is important because we really want to have your view so that we can create a strategy that makes sense at regional level, national level, and European level. And equally, in terms of practical trainings, because clearly we want to address the skills gap, we have also done, of course, we have gathered skills intelligence. We started from research on the ground. We have done a focus group in countries. We have done dialogues in countries, and we have also run consultations with over 600 health and care professionals. And it has been very interesting to notice what have been the results of these consultations and what are the trainings that have been developed. And some are very, what we could define very, very basic trainings, because the level of skill is very different across countries. I was very impressed to see that one of the training is how to use the Microsoft Suite, so the different Word and the Microsoft Forms and so on. And clearly, this is a very, in a sense, privileged room where we can discuss about the GDPR and the European health data space and health records. But the truth on the ground is sometimes very different. And so we need to really, again, create something that makes sense for the workforce.
When you presented at your annual project meeting, the skills metrics, but also the training, the video trainings, I was quite impressed about the granularity and the evidence base of. So it's not just we're talking very general about digital skills or green skills, it's really quite meticulously put down what are the skills.
Indeed, and this is what I was mentioning before. Really, it's not just a meeting of a few people. We really have gone on the ground and really asked the health and care professionals. We asked the nurses, we asked the doctors, we asked the junior doctors. We really asked everyone, what do you need? What does make sense to you? Not for us.
And what do you think are the chances now? The project is running a little longer than the other projects. Yeah. What do you think are the chances now that the great work you're doing will also have impact in countries and will be used as a model or even to some extent adopted?
Well, we hope very high. Our chance is very high, I hope. The truth is that, of course, we're talking about what this could be lifelong learning or continuous professional education. And so clearly one important thing will be to include this in curriculum for a new generation of health and care professionals, but at the same time making sure that also those that are already in position continue to have those skills improved, increased, and so receive upskilling and reskilling.
Thank you so much, Federica. Very interesting, and I'm curious to hear more from the Be Well project, actually. Lisa, last but not least, we are turning to you, but before you wait, think about, we had Johan telling us about the big shift that is necessary, that we need to have the big structural reform, primary care as part of it, integration care. We heard Marco and almost everybody else that digital skills are key. We heard a training and skills requirement from Anke for addressing the medical deserts. You were all about skills, actually, about the tasks and the skills necessary to shift, and your intervention was exclusively about skills. And now it's your turn, and you plan for these people. You plan for the next health workforce, for the health workforce of tomorrow. How do you do this? Joint action heroes. Lisa, please.
Okay, thank you very much, Matthias. It's a pleasure for me to be here with you today. It's a pleasure also to speak about the Joint Action Heroes, which is not the first joint action on health workforce planning, but you have to know that it's the result of two important predecessors. That was the first joint action on health workforce planning and forecasting that finished in 2016, and second joint tender in 2020. When I talk about the Joint Action Heroes, I have to explain you two different paths. One is the implementation path, and another one that is a wider ecosystem approach of that aim at involving all the relevant stakeholders and policymakers. And when I talk about implementation, I refer to the three different phases in which the Joint Action Heroes is divided in. In fact, each country that is participating in the joint action has to face the first phase as his phase. He has to describe the current situation in terms of data, model of health workforce planning, and tool and skills of the planners. And the to-be phase refer to the objective each country wants to reach within the joint action. And the to-do phase is the implementation, the action they have to do in order to reach the objective. Now we have just finished the as is and to be phase, and we are planning to start the implementation. And you have to know that at the beginning of the joint action, the idea was to divide all the member state participants in 3 different clusters according to their similarity of their national healthcare system, and also according to their health workforce mobility. And the idea was that each country could have learned something from other countries within the same cluster. But one important lesson learned that we have so far is that there are similarity across different clusters and differences within the same cluster. And an example that I want to bring you, because we are very glad to explain you, is the country of Malta, because it's a very small country, but it's working very well in the Heroes Joint Action, as it is trying to implement, with the support of WHO and NIVEL, a model that is in use and it's already implemented in the Netherlands. So, and it is specifically about the emergency doctor, general practitioner, and a few professional groups. So this is a very good example on how countries can learn each other, can act a mutual learning.
But that's very interesting. The Maltese case is important to learn from, because they say we have a particular model of care and we want to emphasize this, and that, and for this we need to make the planning particular specific, isn't it?
Yeah, and they chose the Netherlands because Netherlands has one of the most advanced models in Europe now. Yeah. So, and also because Netherlands is also our task leader of the model in Heroes Joint Action. So, and now I had a meeting with them last week, and they say that they are trying to push their stakeholder and policymaker to try to study the model and try to implement it in their system. So let's see. And another important example is Italy, because Italy, thanks to the first joint action, had the first forecasting model, and it was a stock and flow model that is able to predict for 20 years. And it was developed by the Ministry of Health in 2016. And in 2019, the National Agency for Regional Health Services, AGENAS, created another model that is a model that states the staffing needs at the organizational level, and it is in the public sector, obviously. And this model is aimed to fill the gaps, to state the gaps between the demand and the supply. So what we are doing, what Italy is doing in Heroes, is not only to try to improve these 2 different models, because they found different items, but we would like to integrate these 2 models in just one, in a more complex and much more complete model for the future. And also, we hope that for the future, it will be possible to talk about a European healthcare workforce planning in order to better understand also the healthcare mobility, the healthcare workforce mobility, because we are in a common market that is dealing with issues that are going beyond the national border.
Lisa, can I ask you, in the past, one of the challenges for health workforce planning and forecasting was a lack of timely and accurate data. Is Heroes also dealing with it?
Okay, I have here the expert in data, because she's the leader in Heroes about the data. But yes, I think that one of the most common challenges in all the country is the collection of data. Even despite there are countries that are well prepared and they are able to collect data, as for example Norway, this is one of the most important issues, because there are disaggregated data in almost all countries. I don't know, Esther, if you want to add something.
No, it's good. Thank you. Excellent. Very good. Thank you so much, Lisa. So I think we had quite a panel, and please, everybody, a big applause for these fantastic interventions. And we started with recruitment and retention, medical deserts. We had skills, task shifting. We had, again, skills for green and digital tasks, and now the workforce planning and forecasting. And I can figure that you all have questions, and probably also some questions are coming through the chat. We have a couple of minutes left to address them before we wrap up and close the door. And I've asked the panelists not to respond to each of the questions, but only to respond to those where they feel best suited. But we will make sure that your questions are all covered. Please, Alice.
Thank you, and thank you to all the speakers for your interesting insights. There was also an interesting discussion in the chat, and I picked up a few themes that were raised. One was about concerns over the health workforce pay gap across European countries, and how can we avoid medical deserts when medical professionals are paid unequally across countries, so avoiding that they look for opportunities where remuneration is more interesting. Another concern that was raised was about the representation of the health workforce in such discussions. So how can we ensure that medical professionals are really taken into account and their experiences are considered when proposing solutions to improve the health workforce? And then thirdly, another interesting thought was about the role and the space of non-EU but European countries from which a lot of the EU workforce comes from. And how do we avoid, does that mean also investing in these countries, and how do we avoid then potentially the creation of medical deserts there?
Alice, thank you so much. We park these interesting questions for a moment. And I saw already a hand up there. Do we have a microphone? Yes, please. Please say who you are and your affiliation.
Hello, thank you. My name is Lovro Markovic from the Austrian Ministry of Health and the Youngest Diner. It was mentioned that we need to keep patients outside of the hospital, among others, to reduce burden on healthcare workforce. So the way you do that is through public health interventions and, for example, primary, secondary prevention programs, which lie outside of the expertise of clinical experts. So I'm just wondering what is being done to address or ensure a robust public health services infrastructure and public health expertise. Thank you.
I think we can take another two and then we have a round of responses. Yes, please.
I would like to add some, Elisabeth Rappelt from the Austrian Public Health Institute, and I would like to add something for public health issues, because what we face in Austria is, for example, we introduce community nurses, which are community health nurses more or less, and we think it's utmost important to keep the nurse, also when it comes to nursing, the workforce fluent, and we need to have them coping with people who are really in need, and therefore we try to push up the need of nursing there. And when we tried to introduce this system in Austria, then this was this discussion from hospitals and nursing homes. We need our nurses there. You can't take them away and train them to school nurses, to community health nurses, to public health nurses, which doesn't add up, because we need to train them also for these areas, because we need to make our people more healthy, more health literacy, support them in health literacy, and keep them out of the system. So that's quite interesting. How can we address this? Because we need to have them also in working in preventive areas.
Very good. And one more question here in front.
Hello, Catherine Fior, Your Active Health. Johan, you said that this requires a European solution. What do you expect from an EU level? And Marco, can you deliver that?
Actually, it's a very relevant question, because the health workforce was one of the key themes of the Belgian Council presidency. And from the Council presidency, there came the plea that the EU institutions help member states developing health workforce policies. But Johan, maybe you want to start. Actually, a couple of questions refer to what you were saying earlier. Also, the non-EU countries and the mobility, and the grass is always greener on the other side in the other country. Please, Johan.
Can you hear me? Yeah. Yes. So let's start with the last question. What do we expect from the EU? I think in our conversations with the EU Commission, we always feel a certain reluctance on the side of the EU to be involved in things that are still within the remit of the member states. Health is still a national competency, and so the European level can do what is complementary to what the member states can do. What we would like is that, first of all, that again, this is a problem we're all facing, and we don't want to reinvent the wheel in every member state. So what we would like is that there would be funding, of course, to set up international collaborations to look at these problems, and we are very much aware that healthcare systems differ in different countries, so we will need to take into account the difference between the healthcare systems that have grown over many years and that reflect also the culture in different countries. But we would like the EU to take a more active attitude to help us implementing, because, I mean, it's more easily said than done, and some of the problems were already raised. We will need to have a transition phase where we train people to go working in prevention. That will lead to less people working in the hospitals or in long-term care. But to make this possible, we'll need a lot of study, not least on the reimbursement factors, because a lot of hospitals, even university hospitals, are financed by doing secondary care. So to move this care as much as possible outside of the hospitals, we'll need a very long transition period that is very well studied, where there is taken care and looked at all the different implications. And that is something we believe we cannot do at the national level. We should be doing at the European level, where we should collaborate at the European level. And it is something we need to start now. And there's also, as I already mentioned, our responsibility as university hospitals. We need to accept this, and to accept that our task is not only tertiary care, the next brain transplantation, but our task is to advise how to keep our population healthy. To be honest, for example, public health in our universities is not the most sexy department to be in. It is a department where the lesser gods are employed. Not wanting to insult everyone, but that is the truth. You don't get publications in Nature or in Cell by working in public health. So there needs to be also a cultural shift, that we as universities need to be responsible for public health. Maybe not organizing the public health, but at least advising how to get there. And that is what we would like the EU to be more involved in, to make this possible.
Marco, you were sitting yesterday on the panel for the investment hub. Would that be an option, to help member states implementing their workforce strategy?
Certainly, I mean, also to reply to the questions, if the call is for, say, funding plus supporting the collaborations, then the answer is very easy, and you can figure it out, because this is what we are actually already doing, and the fact that we are presenting this, it is also an effort to make sure that we are on the same page when it comes to what we have achieved and what we need to tackle in the future. So that's number one. Number two, I wouldn't call it reluctance, but rather respect of the principles of Article 168. But notwithstanding the fact that there is an investment in analyzing the causes and where we can intervene, it would be, as you say, probably the instruments of support to the member states would be one of the directions. And if I may, I think that, well, probably anticipating also some of the elements in the closure, I think that these elements of context specific comes around. So here the challenge is to devise a solution at the European level that link up with something that is implemented in a very context specific element. So, I think that is a common element which would also come towards, let's say, a response to your effort. So, and I guess that by having this exercise with projects that are covering such a span, it is also, it is where we can catalyze the replies. And yes, it links very much with what we said yesterday. And by the way, the second one is on data, but I will elaborate that.
Okay, cool. There were questions with regards to health promotion and prevention. It was the theme of trying to keep people outside the hospital, but it was also about skills, actually. How can we transfer skills from a nursing profession to a slightly different nursing profession? How is that possible, And maybe we can have here a couple of views. Anke, maybe you can say something about Esther, you're nodding. I guess you can also, you want to start?
Yes, thank you very much. So basically, we are exploring a new skill set that has arrived to the health workforce, and it is a really huge transversal skill set that we can see, and it is including mental health, coping with mental health issues. It is including mentorship. It is including more preventive measures. It is including task shifting itself. So basically, we do see the change in the skill set and the mindset mindset of the people. If you would like to really implement task shifting, it's a cultural change that we have to, a mindset change that we have to implement. That is really a long process, and it has to be interprofessional, just breaking the silos of the different professions.
But Esther, I think one of the challenge our colleague here was referring to is that nurses, which are mostly part of the task shifting, we don't have them in abundance anymore, We have difficulties, and it's difficult at the same time to shift one nurse from a certain context, from a certain nursing profession to another. What do we do?
Not only considering nursing profession in this picture, more wider. I mean, we have several different cases from different countries where tasks were shifted to pharmacists, for example, or other professionals, physiotherapists, for example. So it's really a good practice. We have also from Lombardy in mental health care some shiftable tasks that were already practiced and tried out. So basically, the context is very, very crucial, but we can find like some pillars that could be agreed as an international level, for example.
Thank you, Esther. Lisa, can I ask you something? We had two questions regarding mobility. One was from countries outside the EU, and also, that people may go because European citizens are entitled to mobility, go to other countries. In your modeling, in your forecasting models, does it really play a big role, this mobility?
Okay, thank you for the question. It's a very difficult question because one of the most important challenges that we have in Hero Joint Action is the mobility. Because in a lot of countries, there is no information about the mobility, above all for the outflow of the professional. And I can tell this because we have this problem in Italy. So
it would be actually an EU role to monitor this, wouldn't it?
Yeah, in fact, in talking about our colleague, we are thinking about in the future what could be improved in another project or in the future joint action if the mobility.
Thanks a lot. Yeah. Mario, very briefly, because we want Marco to wrap up.
Yes, also on that point, and the first question on the impact of the mobility flows on medical deserts. Indeed, the role of the EU could be to overlook the big picture, as we are all fishing in the same scarce pond of human resources. And indeed, as we hear, we lack data on it. And we should move away from competition between the member states, but further collaboration, whereby the EU can play a facilitating role for sure. Thank you.
You picked up actually the line of the workshop theme, collaborating for health workforce excellence. So thank you so much, Mariel. And Marco, please, your wrap up.
This is quite an interesting and complex role now to run up with such a level of insights. But first, let me thank you all for participating, for seeding elements for further discussions that we may continue in other settings, so first of all. And I also would like to thank you, Matthias, for your effective and dynamic moderation. So I take the first element that I would take as wrap up is this need for, linking these very complex challenges that we heard today with these context-specific situations, which means that our collaborations efforts needs to link what we can do at European level through what we can do at contextual, at very specific and local level. Now, and there are elements that are coming up. So first of all, I think that Johan quite well described this differentiation between the long-term activities that can be pursued by, reforms to activities that can be done at the mid-level and at the very short, at the short level. But all of them, once again, which by the way came up also yesterday, links to the fact that we are equipped with tools that allow us, first of all, to model the situations to make the case and generate evidence. that calls also for activities and actions in that sense. And the second, it's about the availability of data that can feed this model. And this, once again, recalls the relevance of what we are doing with, say, for instance, with European Health Data Space. Another element that frames the discussions into what we hear is to say new ways of working is that, well, essentially operating like in the past, it's not the right receipts. And in that sense, innovation would be the catalyst. And once again, in that sense, probably the way in which we embark this technology, say the digital technology, can also help in mitigating the issues. And in that sense, this would apply, as you were saying before, to several issues that they tackle. So even from task shifting or for task sharing. Now, the interesting elements here is to strike the right balance between what we regulate and how do we support the adoptions of these technologies, again, from, say, European level to the local level. The other element that I would pick up is that, if the technological solutions may contribute to this discourse, then we need to tackle the issues of interoperability of data between different systems, because otherwise, say, even the exchange of that data may not be, sufficiently serving the purposes. Now, the second point that I take, so in this context of, let's say, mobilizing innovation, is that it emerges, probably because we are in a setting where, it is a European setting where we are discussing, is the preconditions of collaboration and partnership. And also the consensus building approach, this participatory approach that you were mentioning before. Now, I link this to some of the comments that we heard that are worth reflecting, because, in the context of collaborations and partnership, you mentioned that there are changes in several dimensions. So even on digital, it's not just an uptake of digital technologies that is that you are suggesting, but is rather analyzing, say, the organizational and the cultural changes that are attached to that to make sure that then the technology or the new approach delivers. So in that, this shapes the discourse around collaborations and partnership very well. So in essence, there is no one-size-fits-all solution. But it is true, this kind of events and projects, and out of these projects that we can improve and potentially drive also us forward. So I think that I would close this with this call for cooperations, and also in reply to the question what we can do is that continue these discussions even further, focusing on the topics that are emerging from these projects and help us. Certainly we will not spare any energy to make sure that this happens. So thank you again, Matthias, for the great presentation.
Many thanks for your wrap-up. Many thanks for organizing the workshop, and many thanks for your leadership. And we count on you on continuation of this leadership, so thank you. And please look up our Twitter, Observatory Twitter, Ops Health. You find the tweet with all the Twitter handles so that you can connect to the projects. Thank you so much. Bye. So was good.